possible. So thanks everybody for joining us in our 4th installment of the COVID-19 Think Tank. Very excited. Like I said, this is the 4th installment, so we've had a lot of previous discussions and we're looking forward to continuing this today. My name is Allie Hobbs. I am the chair of the Young Professionals Community of Practice with the Society for Health Systems. In case you guys don't know about Society for Health Systems, basically we're a group that our main mission is to improve lives through better healthcare delivery. We have a few community of practices that allow individuals who work in healthcare to collaborate together or across the gamut to work on process improvement in projects, do knowledge sharing like we're doing today, and just create a community that supports everybody and everything they might need. So if you're interested in joining, there's a link at the bottom of this slide, and we'll be sending these slides out at the end of this presentation. Like I said, we've been doing this for a few weeks, so we have recordings on the past weeks. If anything pops up today that you've heard that we've talked about in previous discussions, feel free to go back and look at those recordings. And this one will also be recorded today, and we'll again send out that link with the presentation after today. So I know that was pretty quick, but I wanted to give as much time as possible to our presenters today. As with previous think tanks, we are open to discussions or questions throughout the think tank presentation. You can either unmute yourself. Everyone is on mute right now. So you can unmute yourself to ask a question. You can ask it in the chat, and either Erin or myself will restate the question for you so we can talk about it that way. Or you can raise your hand and someone will unmute you. There's a lot of different ways to contribute. We're looking forward to that on this call. Like I said, we have a couple of speakers today, and they're going to go in order of Dr. James Finian, Avi Fishman, Panos, and Michael Zimmer. So with that, I'm going to pass it off to Dr. Finian to talk about some models he's been doing at the Healthcare Systems Engineering Institute.
Great. So you're making
Yep, I just did that. Should be able to share. At the bottom, there's a button, third from the left, the little arrow pointing up.
There we go. Oh, all right. So I'll share straight from my desktop. So let's see. First, while I'm calling stuff up here. This will work. So I have no idea what you're looking at right now. Are you seeing a spreadsheet or?
Yeah, spreadsheet right now, and we were. And now we're seeing the website.
Ah, perfect. Okay, well, thanks for giving me a little time. This actually connects to the PPE topic. So I wanted to orient folks very briefly to this hospital surge capacity forecast tool that we've developed and posted for free. First off, I want to just applaud the Society for Health Systems. I'm past president of SHS, and I think you guys are just doing and now run a Healthcare Systems Engineering Institute. So I'm a little less involved in SHS than I would like to be, but I think I applaud, you're doing just really a great job overall, and now sort of running events like this around COVID. So kudos to you. So we've been doing a lot of work on epidemics for like 10 years, and we've adapted everything we've been doing to COVID pretty rapidly, and I could talk at length about all of that, but what I want to show you is this capacity model. And so you can find it on our website, which is hsye.org. And if you just go to COVID tools, let me show you some resources. There's a video that I won't call up, but it's sort of a 7-minute YouTube-ish video stepping through the tool and how to use it in a little more detail than I'm going to show you. There's also a white paper. I don't know if that'll open. There we go. Hopefully you can see this document that just gives an overview of the tool and types of questions you can answer with it, how you can use it, a little history on it. But are you seeing a PDF file right now? It should say appendix, large view of tool.
Yes. Yep.
So this is basically a screenshot, and what you're looking at is the 30-day ahead predicted hospital census by unit type, either regular medical surgical type of unit, an ICU, COVID specific unit. You're also seeing in gray the number of patients who are actually ventilated. And on the bottom, what you're seeing is the burn rate, the consumption rate 30 days into the future of any type of equipment you want to enter. I mean, this is PPE, it's masks, it's shields, it could be disposable stethoscopes, it could be some of the dwindling medications that people are using to sedate people who are intubated to keep them from shaking as much, which of course consumes some of the oxygen in the blood, and when blood saturation isn't what we want it to be, that's a bad thing. So it allows you to track all that. Now, hopefully you're seeing the spreadsheet itself. So the resources on the website, how to use it in a white paper. We've got 5 worksheets set up. There's basically line by line, what do I put in for inputs? I'll talk you through that very briefly. There's an FAQ tab, which is basically a running journal of questions people are asking me. I've become sort of user group coordinator. I'm getting, which I love doing. I'm getting, you know, a dozen emails easily every day with people asking questions and could I look at how they're using the tools and so on. I try to update this. So here's what it is. You've got demand for bed, consumption of PPE, and this is actually going up hopefully tonight, but basically staffing. You know, how many staff do I have offline because they're exposed themselves, and how many staff do I need based on my projected census. So this isn't historical. This is a month going into the future. What you input is basically information on your planning period. There are drop downs, 1 week, 2 week, 4 weeks, 2 or 3 ways you can basically forecast or fit data to your projected new admissions of COVID type patients. How many are being tested, how many are testing positive and needing admission, things like that. Your non-COVID patients using historical averages, or if you have seasonality trends, that manual reads off a column over on the right. Then right now I'll show you this in deterministic mode, but there's a simulation component. Also, current census, this is basically midnight census between Thursday and Friday night. Historical averages on lengths of stay and percentages of COVID patients and where they're getting admitted to, and regular patients and where they're getting admitted to. And really some high-level flow paths. You can't capture everything in a quick down and dirty model like this, but percent of COVID patients on a medical floor that eventually need to escalate into the ICU, percent of ICU patients that eventually need to be intubated, vice versa. Once they're extubated, what percent get extubated versus departing the health system some other way, transfers, discharges, or unfortunately mortality. You put all that information in. You can also put, although it's not required, your current system capacities. And depending what you select for inputs, this is the most kind of tricky thing. I mean, people have asked me how accurate the model is, as probably everybody on the phone knows who builds models. Like, the model's 100% accurate. It's a question of how accurate are the inputs to the model. So we've been working with 5 health systems to track the data. They're reporting 85 to 95% accuracy, 5 to 7 days out. it's a little seat of the pants right now. We'd love more health systems to partner up and just share their data with us. But you can sort of see what it's predicting out. If we pick the random option, of course, as industrial engineers know, nothing's for certain. Lengths of stay are random, admission numbers are random, and everything. And then if you hit, however you do recalc on your computer, for me it's F9, for some people it's function F9, and so on, we can see a random future month. So you could just hit this 10 times and get a sense for the random future. There are tables that are kind of small on the, all this prints out to 8.5 by 11. So we took the tables and put them on a separate page. So you just print this and run to your bed huddle or surge capacity meeting. And then there's a tab on PPE, which based on hospital occupancy by type of patient and where they're located and your historical consumption rates projects out what your burn rate is going to be. Again, 1 to 4 weeks into the future. And based on your current inventory, how many days of inventory do you have on hand until you would stock out? I mean, ignoring replenishment. So if you had less than, like, you can put in this threshold ever you wanted, but 3 days or less on hand stock, you're going to want to get into expediting mode. So health systems are using this to basically say 3 or 4 days out, we need to open up new space for ICU patients. We need to convert space. We need to move patients out of med-surg units so we can use that space for COVID patients. Hopefully, at the latter part of the epidemic, you'll be able to use a tool like this to say, when can I convert space back? Things like that. So PPE links to bed occupancy, staffing. I'm sorry, we've got it hidden right now because we're sort of debugging it, but ICU nurses, what's the exposure rate? How long does it take to test them? Then how long, if they test positive, do they need to be isolated? So how many staff are from your pool are unavailable? What's the staff demand based on bed occupancy, and what's the mismatch? So that's the tool. I know that's a high level overview, but hopefully it's good enough. This is on our website. ARC is putting up on their website. It's already on the Institute for Healthcare Improvement's website. It's being used as far as we can track in 10 different countries. And we're just trying to push it out there. It's not a perfect tool. It helps kind of do some what-if scenarios. What we tell people is to, if you don't know inputs, play around with a couple possible inputs and get a range for the future. We're actually this weekend adding a tab that's going to help self-calibrate the model because garbage in, garbage out type of thing. And the most difficult thing for people is estimating the inputs. So we're continually updating the tool on our website. I realize some people are downloading it and using a past version, and we're just encouraging people to circle back every now and then, download the latest, because we're just trying to add stuff in real time as we hear from people what would be useful. Allie, that's it. If there's discussion, that's great. If you need to move on with your agenda, that's fine. If anybody wants to contact me, you can pull this down for free from our website and email it to anybody you want, which we encourage you to do. But if you'd like to be part of like a sort of a user group informally to give me feedback and sort of track, it'd be better if it did it this way or this input. I can't, the wording is confusing. I would love to create a small community that helps us kind of tweak this over time. We're trying to get ready, of course, for the second wave, which is if you work in this space, almost certainly there'll be a second wave of the epidemic, and this will be useful then also. So I'll hand it back, Aaron, to you and Al. Thanks again for the time.
Thanks, Dr. Vinian. I also want to say we'll be sending out the link to this as well as his contact information if you have any other questions. Looks like there is one in the chat we can hit real quick before moving on. Can we use something similar in a blood bank setting for processing convalescent plasma donors? I hope I said that right.
Somehow I lost my, oh, you've taken the ball back. Great. my screen was going.
Sorry.
I'd love to hear more about that. I don't see why not. And, there's going to be the post-acute care setting capacity problem coming up, kind of over the next month. So that's exactly whoever's chat that is. I would love for you to shoot me an email and we could talk more. I presented all this to the VA health system, thinking, of course, we had built in everything anybody would want. And by example, their issue was, how could they use this to better manage capacity to care for mental health patients because of the population that they serve? So I'm not sure if you're talking about like capacity of the blood banks or one of the critical supplies. Maybe that's what your question's about. Like, how can we forecast out when we're going to run out of blood, platelets, et cetera? I can't see chat for some reason.
Yeah, we'll have him reach out. Like I said, the email is in the PowerPoint. So we're going to have to move on to our next presenter. But thank you so much, Dr. Binion. And please reach out to him if you have any more questions. The next up, we have Avi Fishman.
Yep.
Good afternoon, everyone.
Hey, Avi, I passed you the ball so you can share your screen.
Okay, I'm going to do my best to do that.
It's the third circle from the left, the one with the arrow pointing up on it.
Okay, there we go. Okay. And I'm assuming everyone can see my screen.
Not quite yet.
Not quite yet. Well, things are slow down here in Florida. Let me know if anything pops up.
And I think you have the presentation also, right, Allie? If you want to pull it up on your end.
I can't bring it up. Okay, I'm not succeeding. Allie, you're more than welcome to bring it up.
Okay. I'm making you the presenter, Allie.
I apologize.
Oh, no problem.
Okay, we'll just make that bigger. There we go. Bigger, bigger. Good afternoon, everyone. My name is Avi Fishman. I'm the Director of Process Improvement at the Memorial Healthcare System in South Florida. Ali, you can go to the next slide. So we're located in Broward County. So there's a map up there, so you can now see where we're located. We're above Miami-Dade. We're in the southern district of Broward County. Everyone knows where Fort Lauderdale is. We're not too far from the beach, but we're not going to the beach these days. We have 6 hospitals. One of them is a children's hospital. They're spread out throughout the southern part of Broward County, as you can see on that map. And we're just beginning to see an influx of patients with COVID-19. You can go to the next slide, Allie. Thank you. This is my team. I'm very proud of them. They're doing great work. We posted this on LinkedIn. We're all working from home, and we're all busy. We're putting in very long days because we're working on various critical projects, which I'll share with you today. You can go to the next slide, Allie. So the 3 projects that we're working on, it started off with 2 of them, but now it's expanded to 3 of them. The first thing that we were called in on was to help with setting up a staffing pool. They called it the CISP, the Critical Incident Staffing Pool. They wanted to set up a mechanism to enable people that were looking for work to be matched or married with people that were looking for those that could help them out. Being that we're a system of 6 hospitals, it only made sense that if someone needs a job, we could help them out and not have to go to external resources to fill that position. So with the help of our IT folks, we were able to set something up that people could access through our intranet, and we brought on board both a matcher and a traffic cop, where the matcher would match and the traffic cop would ensure that they were placed within the position. So everything works when people work together as a team. Clearly, this has reduced the need to bring in some outside resources to help us out. But the reality is things don't work when we don't work together as a team. And some individual hospitals have opted to do their own thing. And when you do your own thing, you're really not helping others out. Over to the next project. So critical supplies. Nope, you can go back to that page, but I'm sorry. Thank you, Allie. Next column, critical supplies. So we've been called in to help with specifically PPEs, but it expands to other things as well. As you can only imagine, it's not good to run out of something when you need it, and we're getting low on certain things. So every day I hear a shipment's coming, but I haven't seen the shipment yet, or haven't confirmed that it's arrived. So we have set up our own mechanism to know what's on hand, know what the burn rate is. We can go out 3 days, 10 days, 20 days. We can exclude the weekends. We can include the weekends. But basically, we've set up our own ability to predict what our needs will be. You know, by now, it's really too late to start ordering stuff. So if we didn't order something 2 weeks ago, we're up a creek. We participate with other Florida hospitals in ordering things. Things are getting tight, and when it comes to certain things, we're getting nervous. So it's a good model, but if people don't put things in, we don't have an idea of what's going on. If they don't put in things correctly, we have a bad idea of what's going on. And the reality is it's not going to help us when we're critically short. The third column before we go to the next page is most recently, my boss had the vision to set up an executive data center. It's not everything COVID, but it's those things that people are asking for from the leadership. And we have operationalized it so that we're open 7 days a week. My boss has Saturdays, I take Sundays, but we are helping in getting all this data together so when someone needs something, we can get it over to them. I can tell you that we've been entering data, even though it is somewhat rework when you look at things from a process improvement perspective. Not fun, but we're doing this because we realize how valuable this data is. Allie, you can move to the next slide. So when we look at each one of these, number one, this is not our project, the critical incident staffing pool. We were brought in as consultants. So they definitely called upon the right person to help them, but when you're a consultant, you're not in charge. And even when we are in charge, we seek the input and have people help us lead, but when we're in this consultant role, we're really taking a back seat here. And that is too bad, because sometimes we just have to bite our lips and let them do their own thing. But when people do their own thing and you have too many cooks in the kitchen, things may not taste that good. And clearly things haven't worked out as ideally as we would have liked them to. But I see daily that people are using this tool, especially from the big mothership, where they're calling in people with certain expertise from other hospitals when they need critical care nurses or nurses with a cath lab background or nurses that have worked in other areas that they could benefit from. So it does work, but it only works if we work together. The screenshot on the right-hand side is just from our intranet page so people can see the instructions that they needed. Allie, you can move to the next page. Thank you. So with regards to critical supplies, I have to blank out the data, but every day this report is automated and it comes out. It's based on the information that is inputted from the various hospitals and from Central Supply, excuse me. So we know what's going on. We are now updating this in order to do better forecasting. And we were instrumental in helping set this up. We were instrumental in facilitating the communication between the teams, and we're instrumental in maintaining this and ensuring that things are up to date. So if someone doesn't input it, I'm sure we're going to give them a call. But we work together with our purchasing department every day, and the relationship is a good one. And I'm very happy that this tool is helping us see where we are every day at every location, so that we have a feel for what we need and where. And clearly, if one place is low and another place is high, we can help each other out, because that's what systemness is all about. Ali, you can go to the next slide. And then finally, the data center. So this has been a challenge to set up, and every day there are updates, and every day there are challenges. But the cool thing is that it has enabled us to provide the leadership with the information that they're needing, to add people onto distributions that may not be on them, and to get this all organized. I'm sure when this is all over with, we'll be much better prepared for either the next waves or the next pandemic. So it's really cool to be able to do this, and it's really cool that the leadership appreciate our involvement in doing it. The reality is there's no one better to set things up than people from a process improvement background. So on the right-hand side is a image of the process map, which keeps on changing because things are fluid, but we love mapping things. We've also prepared a booklet for dummies, so people that are doing the data input or manning this during the week that have not yet been trained, it's easier for us to train them. Or if someone needs to take a vacation day, because we're now requiring employees to take vacation days in order to help us reduce our costs, people can backfill the vacancy that's been created and do the work. And on the lower right-hand corner of the screen is a thank you note from our Chief Medical Officer, who does not typically send out thank you notes, so it was nice of him to thank us for the work that we're doing. Ali, you can move on to the next slide. And that's it. That's me wearing whatever facial covering I could come up with. It's 2-ply, so I'm sure I'm protecting myself as best as I can. If there are any questions, I'd be delighted to answer them. I don't know if the questions that are on the screen are related to me, but if there are questions, either send them in or ask away.
Okay, and I think just due to we have 2 more presenters and about 30 minutes left, I think we're gonna move on to the next presenter. So Ali, and if there are questions, if we have time at the end, we'll have questions time at the end, or you can reach directly out, because remember there'll be the contact information. Would help if I unmute you, huh, Panos? Okay, you are up.
All right, thank you so much. All right, thank you all, and thank you for having me. My name is Panos Zeffsta, and I'm dialing in from Lincoln, Nebraska. So I am the Senior Performance Excellence Consultant at Bryan Health, a very wonderful team of folks that really putting a tremendous effort, but not just only on activities, also on their thinking. So I want to take you through a couple of things that I have come across. So I'm pretty sure the audience here today, you're all familiar with systems thinking, and Abby's presentation is really exposing a lot of the elements from that. So as we're looking at PPE, and of course everybody has a shortage of it, we also I also came across the issue where there was the discomfort. Now, not only there were places that they did not have the necessary PPE, but those that we did, we had to do anything we could to help our nurses and our medical staff as much as we can, but also think systemically. So as I was looking at this and experiencing all this information from from the media, and how people were coming together and helping and providing. The first thing I wanted to do is buy a 3D printer and do my part. And rest assured, that's exactly what I did until I stopped and thought more systemically. So the purpose here is to provide our healthcare staff the PPE and conditions necessary to help save lives by minimizing the risk and discomfort. Now, I cannot provide them N95 masks, But what I thought is, what can I do to help them feel a little bit better? Forgive me here, I haven't, there you go. All right. So as I was looking at this, is one of the things that I heard from my fellow nurses from different actually healthcare systems that I keep contact with. They had discomfort with the surgical masks around their ears. The typical masks that you see flying around. So, and as you can see on the image presented there, unfortunately, not the right form of PPE. So as I was looking for, for possible solutions, I fell victim initially of looking at the element of the system, not the system as a whole, right? So there were a lot of folks online that they were printing some mask comps to help them out, as you can see in the pictures. But one of the things that I found out is often that our standard work is not really standard at this point. So anything else we introduce, we have to be sensitive to our standard work. So, so as I was looking at the whole picture, the whole system, we needed to be sensitive to whatever we introduce as a possible solution. We have to be sensitive as to how does one change affect the system as a whole. So how does it affect the process that we might have, or you might have, on doffing and donning of PPE? So if you're introducing a new added element, most likely it's not part of your process. That means that there is a risk of deviating from it, that it can cause issues with contaminating the individual, contaminating the patient, and so on and so forth. So, and as I was looking at the process, as a fellow TWI trainer, training within industry for TWI, I started looking at the process and questioning every detail with a purpose. So as I was looking at it, I said, what can we do quickly to help alleviate that issue? So I developed this job instruction breakdown that really takes this mask and really, if you have a string available, which, thank God we don't have a shortage of strings so far as I know, you can quickly turn the typical surgery mask, instead of wrapping around your ears, it wraps around your head, and actually it's away from your ears, as you can see in the image. But one thing that really, I reflected through this, and I wanted to share with everybody, is that right now, up until this point, we had a biased reaction. And we in the performance improvement world, we had to often drag people and push forward to get things done. Well, unfortunately now, during these circumstances, the last thing we have is a bias reaction. Everybody has some idea, everybody wants to do something. What I want to caution us here, and everybody, and try to influence your thinking, is that we need to be more systemically, more systems focused rather than just action focused, because whatever actions we take now, they can have an adverse effect to the entire system of ours, not just as individual healthcare system, but as a country overall. So just like Abby said, right, we would not be able to succeed that if we're only looking after ourselves. And I wanted to build on that, and we're not going to succeed if we're only looking for solutions that is going to make an element of the system work better. It has to. We have to looking at the fit. So with that said, I want to thank you all, and I thank you for your people that they're doing such an incredible job on the individual systems, and I pray everybody's remain safe and we all fight through this.
Thank you, Panos. And we have a larger version of that chart, that work instruction, I believe, that we'll be sending out as well. So if you're trying to get that really closely. And I hear you're in Lincoln, Nebraska, so go Big Red if you're a football fan. I'm from there as well.
Right now, nothing is going, so yeah.
Yeah, nothing right now. All right, so I'm going to turn it over to Michael. Michael, would you like to flip through yourself, or would you like Allie to go through the slides she has?
I can do it.
Okay.
Share my screen.
Okay, great. Thank you. Yep, we can see it.
Perfect. Oh, hold on, let me flip it. All right. So my name is Mike Zimmer. I'm with Vidant Health, senior business consultant, IE background, and with a team called Systems and Procedures. So our department, kind of like a lot of the other process improvement type teams out there, been called upon to facilitate and lead task forces throughout the organization around this event. So the one that I've been doing, been a lot around the PPE task force. So I did stuff with the HR, and now we have to think about our strategies all around PPE. So preservation and conservation is the big game. Some of the key points showing on here is strategies around how well we can ensure that the PPE is in best condition as possible. So with extended use and reuse, we need to ensure that makeup and facial hair, all that stuff, doesn't become a factor with the PPEs, because we're also going to be taking those in collections for reprocessing, which I'll talk more about. So the extended use and reuse is obviously anything that we can define from the CDC. Now, nothing is perfect. There's more information always coming out, so these things are continuously evolving, and our processes are always changing, so those information has to be continuously updated. But we did a nice little campaign because, believe it or not, makeup and hair tends to be a very sensitive topic. So the campaign's been good to kind of generate positive reaction and get people involved. And so that sharing of a before and after, we had folks who never shaved their face for 30 years. And so it was a big, big deal for to make that happen. But a lot of compliance with that, a lot of good reaction. So with the collection, that was one of the first things we started at the end of last month. We knew that there was going to be a PPE shortage. And so there was no question about ensuring that we needed to get things going to start grabbing what we can and then figure out the processing that can happen thereafter. So everything that we were doing, none of the FDA was already approved at that point, but we were already mobilizing to get that done last month. We had to ensure that the masks were all separated. We didn't want mask collections to be bothered with gowns and coveralls and with other items. We created materials to show for signs, bins located, colored bags to indicate certain things. So red bags are biohazard. We didn't want to use those because per the CDC, that when they're thrown away, they're just regular medical waste. And of course, you have a lot of FAQs. Is it safe to throw them away with no lid? Is it safe to transport them around this way? All these types of things had to be worked through. We also had to be very clear with the restrictions. If it came in contact with blood and bodily fluids and it was soiled, we're not taking those. Damage beyond repair. And C. diff and TB contact was also important. Any PPE used for patients in that space, we weren't going to collect because our processes cannot ensure to eradicate the spores and those other infections. Our hydrogen peroxide process, which I'll talk more about, can, but not all PPEs will go through that process. And then visitors and patients have to be managed as well. They're an unknown variable. We don't know where they're coming from, what kind of conditions they have, if they're asymptomatic or not. So we want to ensure that we didn't collect theirs. We will collect our staff, our team members, because they've been educated, they should be well trained about the use of PPEs and so forth. And our hospital have COVID cohort units. We are collecting the PPEs from them. Our high use of N95s are from there, and they're a prized commodity. We can process those and have complete sterilization. So it's okay to collect from COVID cohort units. So the collection process wasn't just a particular provider group or a single hospital. We're doing it across 9 hospitals, over up to 150 clinics. Our health system has just about 100 or so. But when we include the university health system clinics involved, the East Carolina universities, they add to that pool. So our bandwidth expands greatly. So we're doing it over the 29 counties in this geography. So the logistics was very key in how we coordinate to aggregate all the collected PPEs and bring them back to our central facility at Greenville, North Carolina, which is in Pitt County. And that's almost a we have a capacity to be over 1,000-bed hospital here. Our census is lower at the current moment, but that's the flagship hospital where we manage our entire operation for Eastern North Carolina. So the reprocessing, we define 3 main techniques. So we've got a decontamination process, which is the dry heat. As of 4/15, we were already operationalizing this. So as of 2 days ago, the NIH validated the dry heat process that we've been using since then. So that's a great comfort to us. We already had the science behind that heat can deactivate the COVID virus. 70 C for 1 hour. Our processes can do 140 surgical masks per hour. So we can kind of go through these pretty quickly and get that going. The sterilization process, we had the STERAD units in our SPD. We're now converting to the vPro. So the vPro earlier this week got the EAU from the FDA, which can do 10 cycles on the N95. The STERAD machines did 2 cycles that the FDA approved for. So we want the longer cycles in the event that we need to keep processing as long as the N95s are in good condition. That vPro also went from 20 an hour to 40 an hour. So our capacity increased in that as well. So that sterilization process was good. What was awesome about it is that when we defined it 3 days later, the FDA came out with the STERAD approval. So we felt that, the logic and everything we went around this was in great shape. And this was in junction working with the East Carolina University scholars there from engineering and microbiology and immunology. The other one is isopropanol wash. So the isopropanol has the high alcohol content required to deactivate the COVID virus. So the PAPR hoods are made of Tyvek materials. We can use that to decontaminate those. So that allows us to reuse the PAPR hoods. It allows us to clean face shields, the shields for the cappers, goggles, masks, and whatever, any plastic type items. We can use the isopropanol wash very effectively and do that very quickly. We were also very keen to ensure that we ruled out and that we were not going to use UV light. There's a lot of information out there where a lot of folks have converted to use UV light for their N95s. One of the main factors that ruled this out for us was the fact that a lot of PPEs are porous materials. The light does not penetrate into porous materials, therefore it doesn't do sub-level eradication of the virus. And just about maybe 2 days ago, a paper that came out in which the NIH is on this showed that the deactivation of the COVID virus at 90-degree incident of the UV light takes a very long time before you can get to undetectable levels of the virus. So please reconsider that if this is something that you guys are considering or are doing. I highly recommend to change your process to some of the ones that we're representing here. Just because the UV light has a lot more uncontrollable factors to ensure full deactivation of the virus. So our operations is around this with all the collection. We converted a storage unit that's pretty much just on the other side of our central services where SPD is located. So that gave a nice location for the trucks to come by as they are collecting it from our major hospital systems in the region. All the local ambulatory clinics deposit at the local facilities, and then the facilities will bring it to us. They go into the containers. Our facilities guys created a whole new front face, put air conditioning in it. They did that in like 2 hours. It was amazing, these guys, what they do. But from there, it allows us to bring this in very systematically into a dirty room. We're not bringing the PPEs in a sterile environment. So you have to consider having a mini decontaminated area where the dirty items can go in. At that point, 100% check done on every single PPE. So we've got folks examining whether it has makeup, unidentified details with it, damaged, whatever the case is. And we're doing accurate counts. So per the locations, we know what was collected and what passed inspection. Through the whole process, we got 5 quality checks. And then, so what we have is these holding units. And so the holding units, each of those can hold about 88 masks. They can't be touching each other. They can't touch the sides of the metals. They have to be free suspending, and they have to maintain 70 C for that hour. So we're doing infrared checking every 10 to 15 minutes on 3 different levels of each cabinet to ensure concentrated 70 C for that prolonged hour period. And then we also have our STERRAD unit, which will now transfer over for the vPro. So with this, since today, last week, I got the new numbers this week, but in 1 week for last week, we almost did 20,000, almost 19,000 masks. So we had to discard just over half. And it takes a little bit of time for, you know, getting people involved with the makeup and so forth. We did see a decrease this week in makeup, the discards associated with makeup and hair. But you can obviously see that how makeup and hair is a major factor in how much PPE we could save if that wasn't an element that we had to deal with. We tested out doing the isolation gowns. So isolation gowns is huge. If you have 100 precaution patients requiring isolation precautions, you could go through thousands, over 10,000 isolation gowns in a week. So that's huge. So the burn rate on that is high. But we were able to collect those, and we can do about 40 an hour right now with all our systems that we converted over. So after the treatment's done, we have a clean room where microbiology is being done to test on them. Then they go to a converted clean room for packaging that you see in the bottom right corner. Stainless steel tables, the hard floors, we had the facilities guys also put in new ventilation within the room as well, so that we've got the no free-flowing particulates in the air. And they're packaged and they're clean and they're saved away. And so our strategy is that we're collecting, processing now as a crisis strategy for later. And so that's the strategy we're deploying, that, you know, for high reliability, you plan for the unexpected. And then also along with that, our task force is also going into innovations. So we took our blue halyard surgical wraps to make new surgical masks. They obviously are not going to be a 1-for-1, but they do great as a just daily use type of stuff. Right now, they're not approved to go into the clinical areas, but we're making those. And we have folks corralling to take our blue surgical halyard wraps to make masks. 3D printing, this is the design that we've been using to remake face shields. So we've got a number of those, and they've gone through a couple of iterations for improvements. Taking a snorkel mask, putting adapter, adding a ventilator end to it as a new PAPR capper or N95 inclusive face shield in one. We're going to do some fit testing, and we've got options there. And then we're going old school. The isolation gowns are disposable, but everyone's feeling the effect of supply. So we got to look at reusable. Do we go back to manufacture and make reusables that we can wash and bring back into cycle? So those are going to be, that's what we are actively working on at the moment as well. And then new techniques. Everybody's reinventing things. Intubation box, how you don and doff PPE to preserve them as best you can to not damage, to also be safe so that they're safer. A lot of contact for contraction is the disrobing of PPE. Not done the right way, very bad. And so that overall is kind of our background of what we've been doing in our operation. Oh, and here's also a slide. Here's all the references. You got things coming back around about the STERRAD, the NIH, everything about the heat treatment. If you guys want to look over the literature, All that's there. The isopropanol, how we confirm to validate that the isopropanol is going to be a good solution for decontamination. So scientifically given, FDA, all that types of stuff. So feel free to look in and use it for yourself. All right.
Okay.
That's it.
Well, Michael, there was a question in the chat for you. This came from Liang. We've had feedback from our facilities and staff that the plasma gas has an odor, and staff are concerned with the chemicals on their face and breathing it in. How did you deal with this with your staff?
So with this one, since there's going to be a long period of time before these are even being used, I mean, there is a long aeration period. And so at that point, any residuals should be disseminated from that. The chemical in itself, after use, shouldn't be at a point that would affect any health concerns. But that's the thing. We're not immediately putting them back into cycle for the next day or within a 6-hour use. So if that is a concern, it'd probably be best to have them aside to have a time to aerate and just kind of get that out.
Okay, great. Liang, did you have any follow-up question on there? Okay. Another one. Do you reprocess only N95 masks or all masks? And then, did staff express resistance with using a used mask from another person?
So we are doing all masks, any surgical mask, all those types. We're taking anything that we've got. There is concerns definitely about the reuse, and that's mostly just because of the without any knowledge and understanding about what we're doing. So a lot of that is just going to be settled on a case-by-case basis. But as mentioned, it's a crisis strategy. If we have to deploy these, it's just because the fact that we don't have anything left. And there are other healthcare organizations out there that don't have anything left. So it's something or nothing. And so at that point, it would be to the individual and how they feel about that.
Okay. And then it looked like there was one more. Do your central staff count the number of times of reprocessing each mask?
Yes, absolutely. So the N95s are particularly counted just because there is a cycle limit. For like the surgical masks, the isolation gowns, the PAPRs and so forth, those are based on condition. So they can go through the heat treatment as many times as the condition of the material coming back to us can withstand. So if it's ragged, it looks beat up, we're not going to process it. The Tyvek, the PAPR hoods, they're very rugged, they're very durable. So with proper care, they can hold out for a long time. And so there has been no literature to state that our cycles would degrade and damage the material in and itself. So that's just all based on conditional use.
Okay, great. Great questions too. Thank you for participating. If there are any other questions from Michael or Dr. Benyon or Panos or Avi, we can go ahead and field those now if anyone has any.
Mm-hmm. Very good, Dr. Benny. I did like your model there, so be very interested to take a look at it.
Question for Avi. Are you beginning to convert OR, PACU, and other settings with anesthesia oxygen gas settings into ICUs? Avi, are you still on? And that doesn't just have to be for, yeah, go ahead, Avi.
Can you? Okay, sorry. So we have not yet been hit with the surge. We're getting ready. We keep on pushing it off another day, another week. It was supposed to hit us on the 15th, and now we're thinking maybe by the end of the month. So we're getting ready, but we have not yet had the need to do the creative things that others have done.
Okay. That can also be opened up to anyone else out there at a health system, you know, or I know some that we work with at our company are definitely looking at those areas like OR, PACU, places that do have that, like you said, anesthesia and oxygen and gas into ICUs, but I don't know if they've had to yet. I don't know if that's happened anywhere else.
This is Josh. In Wisconsin, we think we've sort of hit our peak. So we've had all the planning on what that looks like, whether that's just even the overflow to other facilities. We're also now just starting to look at like what does it mean to reopen everything and balancing that with just being cautious enough with ongoing COVID work. So very interesting times.
Mm-hmm. Okay. Yeah, and it sounds like Lavana, the one that was asking that question, is in the hospital in New York and the Bronx, and that's what they're doing to deal with the huge influx they've seen there. Okay. Any other questions for any of the presenters today?
This is Allie. I had something to add to that. My consulting firm is tied with the architecture firm, and something that we've heard back a lot is that all these isolation rooms that people have been value engineering out because it's a little bit more expensive to build, that is now a thing that everyone is taking into consideration with this. So that has been a very good thing. One good thing that's been coming out of this pandemic is the architecture impacts. So pretty great.
Okay. Well, I want to go ahead and thank our 4 presenters today for presenting. Thank you so much for presenting the work that you're doing. Hopefully it was helpful and impactful to those that were on the phone. This was recorded today, so I'll be sending out the recording link next week. And so even if people weren't able to be on, they can experience this and learn from this. We'll have another one of these next Friday, a slightly different time. We'll have 3 p.m. to 4 p.m. next Friday Eastern time. So that invite's out there. Just email me if you don't have it for some reason. Everyone should have it that was on. But thank you all for being on today, and hopefully we can talk to you again next week.
Thank you.
Thank you.
Thanks, Aaron and Ellie.
Great weekend.
Have a good weekend.